As you know, there have been two large key trials that have compared the intensity of renal replacement therapy on patient outcome. They are the VA trial done in the United States and the renal trial done in Australia and New Zealand. They're very large. Together they're a body of almost 2,700 patients, and as you see here from the Kaplan-Meier survival plot from the ATN trial, there was no evidence of any difference in survival of patients comparing intensive therapy versus less intensive therapy. And this is from the renal trial. You can see we haven't got enough money to afford colour in Australia and New Zealand. There is also no evidence in patient outcome. They're exactly smack-o on top of each other. So it looks like dose intensity doesn't really matter to patient survival at the levels that we're operating at in these two trials. So although these two trials have essentially identical findings in terms of patient survival, they have some differences. And you can see there some differences in population characteristics. The renal trial patients were a bit older. The VA, not surprisingly, had more males because of the connection with the armed forces. There was more sepsis in the VA group. There was some treatment before randomization in the VA group. There was a difference in time to intervention, which was really quite spectacular. But otherwise, the differences were relatively limited. There were some differences in mortality as well. And if you look at the VA mortality of 52% versus 44% or so, you could reasonably come to the conclusion that due to the differences in patient characteristics that made it look as though the VA population was sicker, had more sepsis, and had more mechanical ventilation and so on, this kind of difference in outcome may be explained by just differences in patient characteristics. But when you looked at the use of renal replacement therapy at 28 days, the difference between the need for continued renal replacement therapy at 28 days in the renal trial versus the VA trial was very striking. This is a threefold difference, and it seems difficult to just be able to explain that on the basis of patient characteristics. So then one tries to look at some of the processes of care that go beyond the patient characteristics that might explain why there was such a difference at 28 days in the need for renal replacement therapy. And of course, my bias has been for about 25 years now that it may be that the way people use modality of renal replacement therapy and that process of care associated with that might account for these differences. And so you can go to the data available from the two studies, and you find that in the ATN trial, by trial design, that said that during the treatment of these patients, when there was hemodynamic stability, the patients could be treated with IHD or SLED, whilst when there was patient instability from a hemodynamic point of view, they could be treated with CRT. Whereas in the renal trial, CRT was essentially the exclusive treatment throughout the ICU admission, and IHD was used just before ICU discharge or after ICU discharge in the wards. These two trial designs yielded a very different number of treatments with intermittent hemodialysis. And please note that the numbers there relate to the different numbers of patients. When you actually look at the number of intermittent hemodialysis sessions that each patient, on average, would have been exposed to, there's a very striking difference, and there was about twice as much intermittent hemodialysis exposure in patients in the ATN trial. Okay, that's cool for the process of care. But then this led me to very seriously want to spend time in the next 3 to 4 years to consider that this difference may be related to the difference in outcomes in terms of renal replacement therapy dependence may be related to this process of care. And to specifically try to address this question is of whether intermittent hemodialysis like starch or aminoglycosides is actually nephrotoxic. Now, there are reasons to believe that that might be true. There is data in the literature from the 70s from Conga showing that in young males having intermittent hemodialysis during the Vietnam War, when fresh biopsies of the kidneys were performed in kidneys that weren't recovering, there was evidence of hemorrhagic and ischemic injury. So it's possible that there's a biological plausibility, if you wish. We know that intermittent hemodialysis can cause hypotension. There's a very large literature to support that happens. We know that hypotension can cause renal injury. There's a large literature to support that. And so all of these things could potentially contribute to delayed recovery. And of course, we also know that there is a greater tendency of fluid balance being positive if you're using intermittent therapy as well, as demonstrated in the ATN trial, and the need to do additional ultrafiltration to do catch up with volume management. All of these things could potentially be mechanisms that contribute to the nephrotoxicity of intermittent hemodialysis if it does exist. Do we have any other evidence beyond these considerations? Well, we have some evidence from Ravi, who performed the first trial comparing continuous versus intermittent therapy, which is now 14 years ago. And this is a trial that randomized patients in 3 units, and there were approximately 80 patients with intermittent therapy and 80 patients or so with a CRT. And indeed, the results of that trial were complex because people moved in and out of the allocated treatment according to their condition. Nonetheless, looking at intention to treat analysis as published at that time, patients that were assigned to intermittent hemodialysis appeared to have a difference in recovery compared to those assigned to CRT. So that, again, suggestive evidence that there is a problem in the interaction between intermittent hemodialysis and renal recovery. And if you looked at the patients that didn't have a crossover, as reported in the manuscript, again, the same pattern suggesting that if you are exposed to intermittent hemodialysis more, then you are less likely to recover. Do we have any other evidence to support that view? This is Max Bell and the Swing Group in Sweden. This is an observational study. They have a large national database where all the patients that receive acute kidney injury renal replacement therapy are tagged and identified according to their healthcare identifier, and where all the people that require end-stage renal failure treatment with chronic dialysis can also be identified, and you can match them. If you do that, then you can follow up people that have been treated with acute kidney injury, either with intermittent hemodialysis or CRT, and you can see what happens to them in the long run. And this is a hell of a long follow-up. This is about 6-7 years. And you can see that the patients that, according to physician preference, were treated with intermittent hemodialysis are much more likely to be on an end-stage renal replacement therapy program on chronic dialysis in the long run compared to patients that were not treated with intermittent hemodialysis, but rather with CRT. Of course, you will say there is a selection bias in that something made the clinicians use intermittent hemodialysis in patients that were, for other reasons, also more likely to require chronic kidney disease management and then end-stage renal failure later on in their lives. And of course, we cannot be sure about that. But again, indirect evidence that is a source of concern. Again, linking intermittent therapy with non-recovery. This is the Best Kidney Study. It's 54 centers in 23 units. Again, according to clinician preference and resource allocation and logistics, some patients were treated with intermittent renal replacement therapy, some patients were treated with continuous renal replacement therapy. And so we were able to compare the recovery of these patients to dialysis independence or recovery from dependence. And again, if you were treated with CRT, you were more likely to recover to be independent of dialysis at the time of your hospital discharge compared to intermittent hemodialysis. So again, observational data, analysis of observational data, we cannot be sure whether this is a representation of a selection bias or a representation of a true nephrotoxic effect. I was lucky enough to have Antoine Schneider as my fellow for 3 years, and as part of his torture of having to work with me, we spent time trying to look at all of the studies that have been published since the turn of the century, providing data on the treatment that was given to the patient in terms of intermittent or continuous, and recovery of renal function. So we identified all of the literature, the reported information on acute kidney injury and renal replacement therapy. Then we removed double publications, incorrect papers. We worked our way down, as you do, according to the appropriate Cochrane protocols, and we identified 50 papers that presented information on renal replacement therapy and had either treatment with CRT or IHD according to clinician preference or randomized controlled trials, and reported data on dialysis dependence or independence. So then we were able to look at the comparison between the likelihood of people being dialysis dependent at hospital discharge at 28 days, at 90 days, or even the longest that was available, which in some studies went up to 6 months or a year. And you can see in this graphic representation that, again, there is a link between your doctors giving you IHD instead of CRT and you being on dialysis at a follow-up period. And so then you can also get some assessment of the exposure, of the amount of dialysis that people were exposed to. And again, you can divide groups into low exposure and high exposure to dialysis. And again, these are imperfect because the data are not very high quality. There is clearly selection bias and so on. But nonetheless, this also supports the view that there is a link between intermittent hemodialysis exposure, the amount of intermittent hemodialysis, and your likelihood of recovering to become dialysis independent later on. So it looks like there is a link in San Diego. It looks like there is a link in Sweden. It looks like there is a link in 54 ICUs in 23 countries. It looks like there is a link in Australia and New Zealand. Looks like there is a link in the ATN and renal trial comparison. We haven't seen Canada yet, but the Canadians have arrived, and of course they've looked at the Ontario database, which is a high-quality, very detailed database, and they looked at whether there was an association between the choice of renal replacement therapy modality and your likelihood of being dialysis independent at follow-up. And again, this is a very large database, and it's looking at 13,000 patients who were treated with renal replacement therapy for acute kidney injury, of which about 6,000 were treated with CRT, about 7,000 were treated with IHD, and you can immediately see that among survivors of this therapy, 16% at the time of follow-up were on dialysis, versus 26% if your doctors had treated you with IHD. And this is almost identical to the swing study data from Max Bell. The pictures and the colors are exactly the same. I wonder whether they did it on purpose. Anyway, it looks really cool. And, of course, the hazard ratios for being dialysis dependent at follow-up and hospital discharge was much greater if you had been exposed to intermittent hemodialysis as your treatment than if you've been treated with CRT. So we're left in a situation where we don't really know whether IHD is nephrotoxic because we don't have sufficient large randomized controlled trials that have compared CRT to IHD and followed people up over the long or medium term to see if there is recovery. If there is a signal, it's a kind of signal that for us to see would require literally 3,000 to 4,000 patients to be randomized for us to detect it in a randomized controlled trial. And such a trial has not been done and probably will never be done. However, if you are persistent and how can I put it, combative, as I am, then you can think of another way of asking the same question, drawing out of randomized controlled trials. And one way to do that is to say, well, look, if intermittent hemodialysis is nephrotoxic, I can't answer that question by comparing it with CRT because we don't have sufficient sized comparative trials. But if intermittent hemodialysis is nephrotoxic, then logically more intermittent hemodialysis would be more nephrotoxic. And that you could demonstrate the concept in principle backwards. And of course, now, as I showed you at the beginning, we have a sort of randomized controlled trial, which is the trials of dose intensity that used intermittent hemodialysis, because those trials would have exposed the patients to more intermittent hemodialysis in the high intensity group. So, for example, in the ATN trial, if you were randomized to higher intensity dose, you would have been exposed to more intermittent hemodialysis. How much? About 76% more starch. 76% more. That's pretty cool. So we ought to be able to see a bit of a difference. It's a very differential exposure. And there is another trial which is smaller in magnitude by Faulhaber-Walter, which was published in Nephrology Dialysis and Transplantation in 2009, about the same time, which also looked at the intensity of intermittent hemodialysis with daily versus second daily exposure, and again presented a very similar increase in the intensity of exposure per patient. So these are wonderful randomized controlled trial-based experiments, not exposing patients to no dialysis versus dialysis, but exposing patients by randomization to dialysis and quite a lot more dialysis. So if it was true that dialysis was a nephrotoxin and it was like an aminoglycoside, now we have exposure to, say, 500 milligrams of aminoglycoside, and then we're going to exposure to 800 milligrams of aminoglycoside. So we ought to be able to see something. So did we see anything? Did anything happen that might make us think that this would be producing a renal injury? Well, these are the trials. Patients exposed to intensive therapy where intermittent hemodialysis was used had a 44% increase in hypotensive episodes and 26% increase in hypotensive episodes requiring interventions beyond vasopressors, a 68% increase in episodes of hypokalemia, and a 62% increase in episodes of hypophosphatemia. This is randomized controlled data, guys. This is not observational now. If you do more intensive intermittent hemodialysis exposure, that's what you're going to get. And of course, I've done 8 years of Latin, and I couldn't help myself, having been traumatized at school. And when you finish something and you wrote an equation, you said QED, that which had to be demonstrated. This is data from the ATN trials and Faulhaber's trial with individual patient information, looking at the dialysis dependency level at different time points of follow-up. So using this information from these studies, this is preliminary data. We're still cleaning it up, but it looks very, very powerful and very, very convincing, at least in its first iteration, that there is a problem. And if you look at the survivors as opposed to all of the patients, you see it again, that there is a link between more dialysis versus some dialysis and recovery. And of course, everyone likes the Kaplan-Meier survival plots because they look so pretty and they make people see in one instant that there is a difference. So, just to trigger debate and upset everyone, it really looks like intermittent hemodialysis delays recovery to dialysis independence if you've got acute kidney injury. This is a modifiable factor. And of course, if you give more of it, you have dose-related toxicity. So it looks like intermittent hemodialysis may well be just like starch or aminoglycosides, or amphotericin, or non-steroidal anti-inflammatory drugs. The more you give, the more trouble you get. And one could say, if one came from Mars and looked at the evolution of the history of renal replacement therapy, that we're stuck with what is probably an injurious historical phenomenon. And really, in 2015, there is no place for intermittent hemodialysis in the ICU of modern countries. Thank you very much.